Hello everyone, welcome back to my YouTube channel, and today we are starting with the high yield systems. I know there's been a little delay, but I'm going to make sure we are on par with what we are going to do from now onwards. And today's topic is cardiovascular, so I'm going to make sure it's like a 1 hour video, so it's not the longest at a stretch, and then hopefully have a few other videos so it's not longer but then makes it easy. Let's start with the embryology. So here we have a few things which we need to discuss about, and then let's go ahead. Okay, so heart is the first functional organ which is developed in a vertebrate embryo. It starts to beat spontaneously by the week 4. Cardiac looping, it's to establish the right and left polarity. It starts at the week 4. So defect in this looping is because of the defect in the dynein, left-right dynein, can lead to asymmetry, that is dextrocardia. It is seen in a condition called cardiac syndrome. Now coming to the septation of the chambers. So here we have septum primum, which is growing towards the endocardial cushion. Remember, endocardial cushions are from the neural crest cells, okay, and these endocardial cushions later give rise to our mitral valve, tricuspid valve, and also aortic and pulmonary pulmonic valves. So septum primum grows towards endocardial cushions, narrowing the ostium primum. So ostium primum gets narrowed, then ostium secundum is formed in the septum primum. Due to the cell death, ostium primum is regressing, and secundum is formed, which you can see here in the image number 2. So this septum secundum, it starts to develop on the right side of the septum primum, and then it starts to cover most of the ostium secundum. This residual foramen is the foramen ovale. Remaining portion of the septum primum, it forms all the way up there, and it forms one-way valve of the foramen ovale. So there is septum primum, there is ostium primum, which is the first foramen which you see here, and then you have septum primum growing towards the end from the endocardial cushions and growing towards the septum primum, like both the ends it grows, and it tries to close the hole, and that is going to be the left door is the secundum, and then you have secondary septum, that's the septum secundum, which develops, and then the residual is the foramen ovale. Later what happens is the septum primum degenerates, if you can see here, and thereby the septum secundum, foramen ovale is closed. That's the ostium secundum is closed. Anyway, so what happens when there is patent foramen ovale? So failure of septum primum and septum secundum to form to fuse after the birth is the patent foramen ovale. So primum and secundum, when they don't fuse, you have a patent foramen ovale. This is usually seen in 25% of the population. It is usually asymptomatic and it remains undetected, but it can lead to paradoxical emboli. What is paradoxical emboli? So venous thromboemboli, which will enter the arterial circulation through the right to left shunt because of this, because this is on the right side and this is on the left, so it goes from the right to left shunt, and this is seen in ASD. So these are the paradoxical emboli that usually end up getting from the right atrium towards the left and then getting into the systemic arterial circulation. So that's there. And then now we have the embryology for ventricles. So ventricles, we have a few important things. There is muscular interventricular septum, then we have aorticopulmonary septum, and the membranous interventricular septum. So muscular interventricular septum forms. This is an interventricular foramen, the opening. So after it forms, there is a aorticopulmonary septum, and that means it has aorta, it gives rise to aorta and the pulmonary artery later on, so the pulmonary trunk. So this septum rotates and it fuses. If you can see here, it rotates and fuses, closing the interventricular foramen. So growth of these endocardial cushions separates atria from the ventricles and contribute to both atrial septation and membranous portion of interventricular septum. So the membranous portion is from the endocardial cushion. What about the muscular portion? Muscular portion is not the endocardial cushion, but it's the septum. It's already getting formed. It's the muscle probably, so it's not endocardium, but it's not the neural crest. Now, ventricular septal defect. This is most common congenital cardiac anomaly, usually occurring in the membranous septum. Okay, VSD is in the membranous septum. Now, outflow tract formation. So, when we have neural crest cells, they migrate, and then truncal and bulbar ridges that spiral and form the aorticopulmonary septum. This gives rise to ascending aorta and the pulmonary trunk, as discussed. So when this doesn't happen, that the conotruncal abnormalities, it gives failure to neural crest cells to migrate. That's when you have the T's, transposition of great arteries, tetralogy of Fallot, persistent truncus arteriosus. Valve development. All the valves are usually from the endocardial cushions. So aortic pulmonary endocardial cushion of the outflow tract, and then mitral tricuspid fused endocardial cushion of the AV canal. Next we have valvular anomalies, which can be all four of them: stenotic, regurgitant, atretic, or displaced. Displaced is the Epstein's anomaly. Now coming to the structures coming from the embryology. So we have quite a few structures here. Let's start with the atrium. So primitive atrium gives rise to the trabeculated part of left and right atrium. Then you have the endocardial cushion, which gives rise to the atrial septum, membranous interventricular septum, AV and semilunar valves. Okay, then we have primitive ventricle, which gives rise to the trabeculated part of the left and right ventricles. Also, the smooth part of the left atrium is formed from the primitive pulmonary vein. Now, smooth part of the right atrium, that is the sinus venerum, is from the right horn of the sinus venosus. Left horn, on the other hand, gives rise to the coronary sinus. Now coming to the common cardinal veins, so that gives rise to the vena cava. Right common cardinal and the right anterior cardinal vein gives rise to SVC. Posterior cardinal, subcardinal, and supracardinal give rise to IVC. Next we have bulbus cordis, smooth parts of left and right ventricles is bulbus cordis. Truncus arteriosus gives rise to the trunk, aorta, ascending aorta, and pulmonary trunk. If you want to go through this, like 22 days, we have cardinal veins, sinus horn, first aortic arch. 24 days, you have the sinus venosus, bulbus cordis, aortic roots, all of that. And then 35 days, you have the primitive atrium, left ventricle is formed. 50 days, it's completely formed. Next important thing is the fetal circulation. Okay, so blood in the umbilical vein, it has PO2 of 30 millimeters of mercury. It is 80% umbilical vein, not the artery. I'm talking about the umbilical vein. So it has oxygen pressure like PO2 of 30 millimeters of mercury and is 80% saturated with oxygen. Umbilical arteries have low oxygen saturation. So we have three shunts. Blood entering the fetus through the umbilical vein is conducted via the ductus venosus into the IVC, bypassing hepatic circulation. So this is the first shunt. This is the ductus venosus. So blood from the umbilical vein, it is getting into the IVC. This is the IVC. And then because of a shunt, this shunt is the ductus venosus. So instead of going to the liver and then coming from the liver, it is directly having a shunt, which is the ductus venosus. So ductus venosus has bypassed the portal circulation, the hepatic circulation. Next, second shunt is the foramen ovale, okay, that is connecting from the right atrium to the left atrium. So what happens is, after the blood is reaching the heart through the IVC, if you can see it, IVC is giving the blood to the heart. So what happens is, from the right atrium, instead of going through left right ventricle and then to all of that, directly to the left atrium, we have another shunt, that is highly oxygenated blood going to the foramen ovale. Next, the third one is the ductus arteriosus. So this is the deoxygenated blood from the SVC. It passes through the right atrium. Let me just clear it out. From the right atrium to the left, right atrium to the left atrium, right atrium to the left right ventricle. It passes through the main pulmonary artery to the ductus arteriosus. So descending aorta, there is a shunt over here, that is a ductus arteriosus. This is because of the high fetal pulmonary artery resistance. So three shunts: ductus venosus, which is not letting it go into the liver and then come into the IVC. So that's one. And then we have foramen ovale, from which right atrium to the left atrium gets oxygenated blood. And then we have the ductus arteriosus, which is instead of going all the way, it goes from the right atrium, right ventricle, and then from the ductus arteriosus, main pulmonary trunk. So these are the three shunts. At birth, infant takes a deep breath, so the resistance is decreased in the pulmonary side. Left atrial pressure is increased by the right atrial pressure. Then we have foramen ovale, which closes. So that is now called as the fossa ovalis. Increase in oxygen from respiration and decrease in prostaglandins from placental suppression. This leads to the closure of the ductus arteriosus. So in the resistance in the pulmonary vasculature is decreased, an increase in left atrial pressure via the right atrial pressure versus the right atrial pressure, and then foramen ovale is closed. So NSAIDs like indomethacin, ibuprofen, or acetaminophen, they close the PDA. Ligamentum arteriosum, the remnant of the ductus arteriosus. Endomethacin ends the PDA. Prostaglandins E1 and E2 keep the PDA open. So endomethacin ends the PDA and prostaglandins keep the PDA open. Postnatal structures, which are derivatives. So from the ductus arteriosus, we have ligamentum arteriosum. It is near the left laryngeal, recurrent laryngeal nerve. Ductus venosus, ligamentum venosum. Foramen ovale, fossa ovalis. Allantois to urachus, that is a median umbilical ligament. Urachus is a part of allantois between bladder and umbilicus. Umbilical arteries, that is the medial umbilical ligaments. Umbilical vein is the ligamentum teres hepatis. This is a round ligament contained in the falciform ligament. Okay, now coming to the anatomy. So left atrium is the most posterior part of the heart. So if you see, the most posterior part is the left atrium. So sorry, not the left ventricle here, it's the posterior part. So mitral stenosis, in situations like that, left atrium when it is enlarged, what happens is dysphagia, because when it is posterior, it compresses on the esophagus, and hoarseness, because it is compressing left laryngeal recurrent nerve, a branch of the vagus nerve, which is also the Ortner syndrome. So left atrium is the most posterior, right border is formed by the right atrium, that's the anterior border. Then we have right ventricle is the most anterior part of the heart. It is most commonly injured in trauma, and left ventricle is about 2/3, right ventricle is about 1/3 of the inferior diaphragmatic cardiac surface. Coming to the pericardium, it consists of 3 layers, outer to inner: fibrous pericardium, parietal pericardium, epicardium. So they are the 3 layers. Then pericardial space is the space between parietal and pericardium and epicardium. That's the visceral pericardium. Pericardium is innervated by the phrenic nerve. Pericarditis is referred to the pain of the is the referred pain to the neck, arms, or one of both shoulders, often the left shoulders. Okay. Now the other important discussion, which has a lot of questions, is the blood supply of the heart. Okay. So first thing first, dominance. Let's talk about dominance. So the right dominance means it is the right coronary artery from which you get the posterior descending artery. Left dominant means it is from the left circumflex. Okay. Let's go ahead and discuss what are these arteries and why are we talking about the dominance and not all of this. Okay. So first, let's go with the anterior view. So left anterior descending artery. This is the main, for the it is most commonly occluded. It supplies the 2/3 of the anterior interventricular septum, anterolateral papillary muscle, anterior surface of the left ventricle. Okay, and then it is supplying the interventricular septum 2/3. Okay, what about the 1/3? 1/3 is supplied by the PDA. So this PDA, if it depends on from which artery it is arising. If it is arising from the right side, the right coronary artery, it's a right dominant. If it is arising from the left coronary circumflex artery, left circumflex, then that's the left dominant. So posterior 1/3 of the interventricular septum, posterior 2/3 of walls of the ventricles, and posterior medial papillary muscle is supplied by the PDA. Now coming to the right coronary, it supplies to the AV node and the SA node. Infarct may cause nodal dysfunction, bradycardia, or heart block. Right acute marginal artery supplies the right ventricle. So the anterior surface of the left, let's just draw like this. Okay, this is the right side, left side. Let me just draw it clearly. Okay, this is the right side and this is the left side. Okay, this is the atrium, this is the ventricle, right atrium and right ventricle. Okay, so as of now we are talking about this anteriorly. Okay, anteriorly there is interventricular septum. So anterior 2/3 of the interventricular septum, 2/3. So not the 1/3, only the 2/3. And then anterolateral papillary muscle, which is over here. So anterolateral papillary muscle and the anterior surface of the left ventricle. This is left anterior descending artery. So 2/3 of the interventricular septum, anterolateral papillary muscle, and the anterior surface of the left ventricle. Now let's go ahead with the posterior view. Okay, imagine this is again right, this is left, but this is the posterior view. Okay, so posteriorly the interventricular septum 1/3 is supplied by the PDA and the posterior 2/3 walls of the ventricles. So 2/3 of the both the ventricles. Okay, one, and then posterior medial papillary muscle. So these three things: posterior 1/3 of the interventricular septum and the 2/3 of the ventricle walls and the posterior medial. This is the PDA. Now in the anterior part, let's go with AV node and SA node. Where are they? They are on the right side near the interatrial septum. So there is AV node and there is SA node. So these, and then the posterior 2/3 of the ventricle, these and the right ventricle is supplied by a branch of the right coronary artery, that's the right marginal branch, and this is right coronary artery. It supplies the nodes. Okay, now we can have the PDA from this PDA, and we can also have it from the circumflex, left circumflex, but it depends on that. And then the codominant situation, you have PD arising both left circumflex and right coronary artery. So coronary blood flow to the left ventricle and interventricular septum, it peaks in the early diastole, and then coronary sinus runs in the left atrioventricular groove and it drains into the right atrium. Okay, and that's the anatomy. Let's move on to physiology. So there are a few things. Tip your cap to your ventricle. Cap is contractility, afterload, and preload. So stroke volume is affected by contractility, afterload, and preload. It is increased with increased contractility, increased preload, and decreases with it increases with decreased afterload. What is contractility? Ability to like contract, or the force. Preload is the load that comes before that they have to pump, so it increases in early pregnancy and stuff. So what is stroke work? It is the work done by the ventricle to eject stroke volume. Stroke work is proportional to stroke volume into mean arterial pressure. A failing heart has decreased stroke volume, that is systolic and diastolic dysfunction. Next we have contractility. Contractility and stroke volume, they increase with catecholamines, calcium, and decrease sodium and digoxin. So let's talk about that. So catecholamine stimulation happens with the beta-1 receptor. So activated protein kinase A, phospholambin phosphorylation, active calcium ATPase, they increase the calcium storage in sarcoplasmic reticulum. Activated protein kinase A, calcium channel phosphorylation, increases calcium entry. So there is increased calcium induced calcium release. That's why it's contracting. So intracellular calcium, whenever it is increased, the contractility increases. What happens with the sodium calcium exchanger? This is where digoxin works. So when there is decreased extracellular sodium, intracellular calcium gets increased because it's trying to balance it out. Digoxin blocks the sodium potassium pump. It increases intracellular sodium, decreases sodium calcium exchanger activity, thereby increasing intracellular calcium. Contractility and stroke volume decrease with beta-1 blockers because decreased CAM. Heart failure with systolic dysfunction, Acidosis, hypoxia, hypercapnia, that is decreased PO2 and increased PCO2. Non-dihydropyridine calcium channel blockers, that is verapamil and diltiazem. Next we have preload. It is the ventricular end diastolic volume, EDV, depends on venous tone and circulating blood volume. Venous vasodilators, that is nitroglycerin, they decrease the preload. Afterload is approximated by mean arterial pressure. Increased wall tension as per the Laplace's law, increased pressure, increased afterload. Left ventricle compensates for increased afterload by thickening hypertrophy in order to decrease the wall stress. Arterial vasodilators, that is hydralazine, they decrease the afterload. ACE inhibitors and ARBs both decrease the preload and afterload. Chronic hypertension, increased MAP, so there is left ventricular hypertrophy. Next we have cardiac oxygen demand. It's CARD. Myocardial oxygen demand is increased contractility, increased afterload, increased heart rate, and increased diameter of the ventricle. Coronary sinus contains most deoxygenated blood in the body. Wall tension follows the law of Laplace, that is, wall tension is pressure into radius. Wall stress is pressure into radius divided by 2 times the wall thickness. Okay, some equations which are not that difficult. So yeah, stroke volume is end diastolic volume, whatever is left between end diastole and systole, right? So it is the difference between end diastolic and end systolic. Ejection fraction is stroke volume divided by end diastolic volume. So ejection fraction is an index of ventricular contractility decreased in systolic heart failure, usually normal in diastolic heart failure. Normal ejection fraction is 50 to 70%. Then we have cardiac output. Cardiac output is Q, that is stroke volume times heart rate. How much is the heart pumping? So in every minute, so heart rate into the stroke volume. According to the Fick's principle, cardiac output is rate of oxygen consumption divided by arterial O2 content minus venous O2 content. So in early stages of exercise, cardiac output is maintained by increasing heart rate and increasing stroke volume. In later stages, cardiac output is only maintained by increased heart rates because stroke volume plateaus. Then we have diastole, that is shortened because of increased heart rate. Ventricular tachy, decreased diastolic filling time and decreased stroke volume and decreases the cardiac output. Pulse pressure is the difference between systolic and diastolic blood pressures. It's directly proportional to stroke volume, inversely proportional to the arterial compliance. Increased pulse pressure in aortic regurg, aortic stiffening. Isolated systolic hypertension in older adults, obstructive sleep apnea, increased sympathetic tone, high output state, that is anemia, hyperthyroidism, and exercise transient, decreased pulse pressure in aortic stenosis, cardiogenic shock, cardiac tamponade, and then advanced heart failure. Mean arterial pressure, that's MAP, that's cardiac output times total peripheral resistance. Mean arterial pressure at resting heart rate is 2/3 of diastolic blood pressure plus 1/3 of systolic blood pressure, that is diastolic plus 1/3 of the pulse pressure. Now, Frank Starling law or the curve. So, what happens is you have a preload and you have the cardiac output. So, it can be stroke volume, and the preload is EDV, that's the end diastolic ventricular volume. So, it is in a Frank Starling relationship. So, force of contraction is proportional to the end diastolic length of cardiac muscle fiber, that's the preload. And increased contractility with catecholamines, positive inotropes, that's the dobutamine, milrinone, and digoxin. Decreases contractility with loss of functional myocardium, that is MI, beta blockers acutely, non-dihydropyridine, calcium channel blockers, and heart failure. Next is resistance pressure and flow resistance pressure. So flow rate is equal to the flow velocity into the cross-sectional area. Resistance is the driving pressure divided by the flow rate. So it is 8 into viscosity, that's the viscosity, into length divided by pi r power 4. So, if flow is directly proportional to radius times radius to the power of 4. Resistance is inversely proportional to radius into the power of 4. Capillaries have highest cross-sectional area, so they have the lowest flow velocity. Pressure gradient derives flow from high pressure to low pressure. Arterioles count for most of the TPR. Veins provide most of the blood storage capacity. Viscosity depends mostly on hematocrit. Viscosity is increased in hyperproteinemic states, that is multiple myeloma and polycythemia. Viscosity is decreased in anemia. So when they are in resistance, you added the total resistance in series, you added in parallel. 1 by RT is 1 by R1 plus 1 by R2 plus 1 by R3 and stuff. And now we have the cardiac and vascular function curves. It is also the cardiac output / venous return and versus the right atrial pressure. And we also have the vascular functional curve. So this cardiac function curve and vascular function curve. So when there is increased inotropy, and actually I will explain this in the next video.